Hello, everyone. I'm Dr. Angela Mattke, and you're watching Ask the Mayo Mom at Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center, and twice per month I host a show about pediatric health topics where we take and answer your questions live. November is Epilepsy Awareness Month, and today we are discussing seizures and epilepsy in children. Epilepsy affects about 3.4 million people in the United States, and about 500,000 of them are children. Think of a school with 1,000 students. This means that about 6 out of 1,000 students could have epilepsy. Joining us for this discussion today is Dr. Lily Wong-Kisiel, a pediatric neurologist and expert in pediatric epilepsy at Mayo Clinic Children's Center. Dr. Wong-Kisiel is also an associate professor of neurology and pediatrics at Mayo Clinic. Her research interest is in medically refractory epilepsy, and she's very involved in the clinical evaluation for epilepsy surgery. It's going to be a great discussion today, so please send your questions in under the Facebook Live video feed, and we will try our best to review them during the live broadcast today. So, Dr. Wong-Kisiel, thank you so much for joining us today.
It's my pleasure being here. Thank you for having me.
I think this is going to be a great discussion, and it's a perfect time in November to really bring awareness to this topic.
Absolutely. This is an important topic for parents to talk about and have some discussion out in the open.
Absolutely. So let's start with just laying some basic groundwork. What are seizures and what causes them?
Yeah. Seizures are excessive electrical sources that comes from the brain, and when that happens, behaviors are altered and it has an abrupt onset and offset. Okay. Epilepsy, on the other hand, is recurrent spontaneous seizures that happens on its own. So one can have seizure if there's traumatic brain injury due to other causes, due to febrile seizures in the very young children, so for example, in school-aged children, but that does not mean one has epilepsy.
Okay, so there's a lot of different types of seizures per se, and so one type of seizure can look very different than another type. Can you kind of talk through some of the different common types of seizures?
Types of seizures depends on whether seizure source is focal or generalized. In general, focal seizures, how they look like depends on which part of the brain is involved. If focal seizure is involving the area of motor function, you may have a child who have facial twitches or movements of the arms and legs that may be uncontrollable by the kid. And other times, focal seizures coming from the temporal lobe area, kids might manifest as fear. Other times, adults can tell you that they have a sensation of jamais vu or sensation of having done something already, or having unusual taste in the mouth or smelling something different. On the other hand, there are seizures that are called generalized seizures, meaning if we have the chance to look at where the EEG source comes from when these seizures happen, what we see on the EEG involves both hemispheres of the brain, not just one focus or one location. For these generalized seizures, there are seizures, absence seizures, where the patient stares off for a few seconds, 10 seconds or so, that may be repeated throughout the day. There are myoclonic seizures, which are quick jerks of the body or extremity. There are tonic-clonic seizures, which are whole body stiffening followed by clonic movements, and that may last up to 2 minutes, and that can be quite concerning for someone witnessing this for the first time. There are drop seizures where either you stiffen, the whole body stiffen, or tonic seizures, or atonic seizures, meaning the whole body loses tone.
Okay. Yeah. So of those, is there a type of seizure that's most common in pediatric patients?
Yeah. So there are certain types of epilepsy syndromes that are most common. Epilepsy syndrome, in contrast to seizure types, refers to the age of onset of the kid who start having seizures. The epilepsy syndrome refers to the type or types of seizures that the patient have. Epilepsy syndrome also includes what we see on the EEG, because there are characteristic findings on the EEG for particular epilepsy syndromes, and what we see on the MRI, and what we know about these group of patients and subsequent prognosis. So the most common type of epilepsy syndromes in kids include childhood absence epilepsy. In these kids, seizures start around school age, between 5 to 8 years of age. These children will have absent seizures, meaning they will stare off for 5-6 seconds, and these absent seizures start quickly, ends quickly. There's no confusion afterwards. They pick up where they start off. And these absent seizures could be quite frequent throughout the day, dozens of times a day, if not treated. These kids, when on medication, on the appropriate medication, could be very easily treated, and their seizures can stop and managed by medication. The expectation for these kids is that the seizures are self-limiting in terms of they will outgrow their epilepsy eventually by teenage years. The expectation for these kids is they have normal development and normal cognition, and at some point after being well treated, typically we talk about for 2 years, can be off of medication. The other epilepsy syndrome that's quite common in childhood is childhood epilepsy with central temporal discharges. Usually we encounter these children in the emergency room because they have their first time seizure. Mm-hmm. These are seizures that start as focal seizures, meaning very often the kids will have twitches around the mouth, or they have numbness around the mouth. Mm-hmm. They don't recognize that as being unusual or different, and we recognize them when they have their first secondary generalized tonic-clonic seizure and they come into the emergency room. The EEG for these patients have the stereotyped central temporal, what we call discharges or excessive activities on the EEG. Mm-hmm. These kids have normal cognition with treatment, if they need to be treated at all, because some of these patients have rare seizures in between. They may have 1 or 2 a year. And so in these kids, they may not need to be on medication on a daily basis. And these kids outgrow their epilepsy, and by around teenage years, they may not need to be on medication if they do start on medication, and the prognosis is good.
Excellent. So you mentioned febrile seizures in the context of that epilepsy syndrome, but not all children who have a febrile seizure go on to develop an epilepsy syndrome.
That's right.
Okay.
So febrile seizure, we consider that as an acute symptomatic seizure, meaning it's triggered.
Okay.
These young children between 6 months and 5 years of age do not have an inherent propensity for spontaneous seizures. Febrile seizures only happen around the time of fever. And so febrile seizures are quite common in children. About 2 to 5% of children may experience febrile seizures some point in their lifetime. Febrile seizures tends to run in families. So if you have a family history of febrile seizures, not necessarily epilepsy, but febrile seizures, you may have other members in the family who also have febrile seizures. Febrile seizures, again, need to be used in the right context. Mm-hmm. They are in children who have normal cognition, normal development, normal examination. They only happen with fever. There are some risk factors. We talked a little bit about family history. Kids who are younger and in a particular age group. About a third of the patients who ever have one febrile seizure may have recurrence. So it's important for families to know that. It's also important for families and parents to know what to do during a seizure,
yes,
right?
Please talk about that.
And so during a seizure, you want to stay calm and start looking at the clock, because timing is one of the things that physicians will ask you about. How long is the seizure? Because 5 seconds will feel like 5 minutes.
Absolutely.
You want to make sure the child is safe, and so the child is seated. You might consider helping the patient down to the floor so there's no risk of fall injury. You don't want to put anything in a patient's mouth. You want to start timing. Typically, most generalized tonic-clonic seizures are stops in about 2 minutes, and there's no need to intervene. For the first seizure, you want to go to the emergency room for an evaluation. For recurrent febrile seizures, as long as there's no injury where you want to go and get it assessed, as long as there's an explanation for the fever, because you want to get the fever looked at. If these are recurrent febrile seizures and they stop within 5 minutes, we want to make sure that the child recovers, and there may not be a need to go to the emergency room.
Okay, excellent. So for families that are, have a child with seizures and you're considering in the diagnosis of epilepsy, what does that evaluation process look like to really make that diagnosis?
Yeah. So the diagnosis involves a careful history taking of what the provider or the parents' witness seizures look like. How did it start? What are the details in between? Were you able to interact with a child, and how did it end? We want to hear about seizure symptoms that are the same, because not every recurrent spells that look the same are seizures. You can have spells that are related to heart rhythm issues. You can have spells for GI issues in the very young kids. And so a very careful history taking is important. From there on, the child typically will get an EEG of the brain, so that measures brainwave activity during awakened sleep. And the EEG, sometimes we have young kids who said, does the EEG read my thoughts?
Yeah.
The EEG measures brainwave electrical source activities and look at, even in between episodes, can tell us whether someone is at risk for recurrent seizures.
Is it helpful for families to get a video of the seizure if they can?
That is extremely helpful, because we know that having that visual analysis can be quite telling.
Yeah, absolutely. And it's also recording the time.
Correct.
So they wouldn't have to be looking at their watch
Exactly.
when they're doing that. But the most important thing is making sure that child is safe before they would turn on the video, right?
Yeah.
Okay.
So if you have two people around, one person can help the child, make sure the child is safe, and the other one videotape what's going on. And if possible, not all seizures are generalized tonic-clonic seizures. And if there are impaired awareness, or if there's preserved awareness, it's important to try to illustrate that. So sometimes I see home videos where it looks like the child is posing because someone is holding up the camera, and they know that whether they think they're being taken a picture of, they want to be as still or looking at the camera. So having someone engage with the kid, asking them questions, where are you, point to the ceiling, those are all very important features that a physician can look at.
Helpful tips. All right, so you have gone through the evaluation process, and as a epileptologist, yes, please.
Sorry.
Yeah.
And so the other thing, as part of the evaluation, depending on the child, an MRI may or may not be needed. So in children who the initial diagnosis is thought to be generalized epilepsy because of the symptom of the seizure, and because of the EEG supportive of a generalized epilepsy, not every patient needs an MRI of the brain. It's a big deal to sedate young children for an MRI. And so in those patients whom we think this is childhood absence epilepsy, the brain MRI is normal, or this is benign epilepsy, or childhood epilepsy with central temporal discharges, the MRI is normal development. We don't do MRI of the brain.
That's a great point to make, because sometimes families will maybe expect that they're going to need some kind of imaging, but it's not always the case. That's fantastic. All right, so if you've gone on to make one of the diagnoses for one of the epilepsy syndromes in childhood, I imagine treatment is a big discussion about whether the child needs medications or not, or other options. Can you talk a little bit about what you use to help control the seizures in patients with epilepsy?
Yeah. So after first seizure, in a normal developing kid, not everyone needs to be on medication. The risk of a second spontaneous untriggered seizure is anywhere between 30 to 70%. The EEG will help us, because the EEG, if abnormal, that showed abnormality that suggests a propensity for seizures, subsequently pushes that likelihood to a higher percentage, up to, if the EEG is abnormal, up to 60 to 70% versus the lower likelihood of 30%. Now, if we start medication, the likelihood of preventing a second seizure is about 50. So if you're at the odds of 50% of starting medication, and your child is one of those patients who may not have another seizure ever again based on history, based on exam, down on the lower end of 30%, you don't need to start medication. And we can wait and observe and be careful. But if the EEG is abnormal, pushing the child towards the 70-80% of spontaneous seizure, then we start medication. The choice of medication depends on what we think, what the seizure type is, whether it's generalized or focal. There are certain medications that are good for focal seizures. There are certain medications that are good for generalized seizures. There are certain medications for focal seizures that can make generalized epilepsy worse. So those are the considerations we would take. Now, sometimes it's not always possible to know definitively after first or second event or after EEG what type of seizure this might be. So we choose broad spectrum anti-seizure medication that can treat both focal and generalized seizures.
Okay. What if the child continues to have seizures despite being on medications at a good dose?
Yeah. So after the first medication, we try the second most appropriate medication. We make sure that with these medication trials in children, they're always growing. Their metabolism is different from adults. We do therapeutic drug monitoring, so we do have to poke the little ones sometimes to make sure that this is enough for that particular child, even though we have certain guidelines in terms of based on weight. After the second medication trial, monotherapy, meaning one medication, we start thinking about medically refractory epilepsy, meaning that these are patients where seizures are not well managed by medication. It does not mean that these are patients that should not be on medication. Anti-seizure medication is still the basis of epilepsy treatment. Depending on the particular patient's history, we start thinking about non-pharmacologic options for seizure management. There are ketogenic diet, using dietary therapy, high-fat diet, low carbohydrate, limiting diet for those patients of different seizure types. For those patients where we believe there's a focal source, we start talking about surgery evaluation to identify if there's a particular focus that may be potentially removed without causing deficit in the child. And there are newer options in terms of using devices, kind of like the cardiac world, where there are pacemakers, there are vagus nerve stimulators, there are more deep placement of deep brain stimulation stimulator. But again, all of those surgical options would require a pre-surgery evaluation.
Okay, and you're part of working with that team and going through that process. What does that look like, the pre-surgical evaluation?
The pre-surgical evaluation involves a lot of different members of our epilepsy program. You start with a neurologist who knows the patient's medical history well, knows about the seizures, what the seizures look like, have a hypothesis in terms of where we think the seizures are coming from. The pre-surgical evaluation also requires a very detailed imaging study. The imaging study to see if we can anatomically see a focus that we can go target. Now, having a focus does not necessarily mean that that's where the seizure comes from. That gives us a little bit more confidence, but a lot of times the MRI could be completely normal. If the MRI is normal, then we have other options in terms of imaging. We can do what we call functional imaging, looking at blood flow, metabolism of glucose used by the brain. We can do more advanced processing of the images, and these are all ways to try to visualize a focus. Simultaneously, as this is going on, we also need to record what seizures look like. So patients are admitted to the Pediatric Epilepsy Monitoring Unit. We might decrease medication to trigger seizures so that they can more spontaneously happen. Sometimes that emission would take a few days. For other patients, it may be shorter or longer. And then our team, and most level 4 institutions or higher level institutions that evaluate for epilepsy will have a team approach where the neurologist, the epileptologist, radiologist, and the surgeons, neuropsychologists all come together and spend time talking about the patient's case. And very often that re-review and coming together of the dedicated time can sometimes reveal additional findings.
Oh, I imagine just getting everyone together in one room talking about the patient is going to just improve care overall and help figure out what the best treatment plan is. That's fantastic. There's a lot of other kind of more experimental treatments that have gotten a lot of press recently, things like CBD, vitamins, minerals, things like that. Can you talk a little bit more about, are those being used in the treatment of pediatric epilepsy?
Yeah. In terms of vitamins, when we talk about epilepsy, we also think about that as a symptom diagnosis, but there's also the need to look further in terms of looking at the causes or the etiology. There are some rare cases where vitamin metabolism can be a cause of epilepsy. So as a part of the evaluation early on, particularly in very young children who have early onset epilepsy, early onset being less than 3 years of age, those would be considerations to look further. And so I think for those children, sometimes supplementation or dietary modification could be a treatment, but those are rare conditions.
Okay.
For the more recent medical studies on cannabidiol, or known as CBD, there are medical information placebo-controlled trials using the FDA-approved substance called Epidiolex, which is FDA-approved right now for two specific epilepsy conditions. One is the Dravet syndrome, which is a genetic condition, and the other one is Lennox-Gastaut syndrome. And so in those cases, we know based on placebo-controlled trials, there is shown to be efficacy for these kids, improved seizures in about 45% in Dravet kids versus 17% of kids on placebo with Dravet. And then Lennox-Gastaut, very similar outcome, improved seizure control in about 43% of the patients versus 17% of the patients with Lennox-Gastaut syndrome. So there is established medical information about Epidiolex, which is the currently FDA approved form of CBD.
Okay, fantastic. As we're kind of nearing the end of our time, I want to get to some of those really common questions that you're having from families in the office, especially when you're giving a new diagnosis of epilepsy. So one of the probably most common things that families want to know about is, how is this going to affect their child's life and what kind of restrictions they might have going forward?
Yeah, so it is scary for parents who have a diagnosis of epilepsy. Your cute little baby, you start thinking about what's going to happen, not tomorrow, but in 10 years.
The future, absolutely.
In the future, and looking for how do you deal with this. Some of the most common questions I get asked are, what are the restrictions? How can we protect our child? And depending on the age of the child, I think the priority is safety, but you also want to think about, how do you do these things safely, and what are my choices? I recommend trying to normalize normal childhood activities for all of my patients. I think they can participate in recreational sports, and even for older kids, competitive sports with the appropriate sports precautions. Other times I'm asked whether kids can go to overnight sleepovers. Can they go to Valley Fair and go on the rides? But again, there's a lot of safety around those activities, whether or not you have a child with epilepsy. So I think having a backup plan is important. We educate our parents about what to do when seizures happen, and in selected patients, your physician might talk to you about a seizure action plan and what medication that you can use only if the seizures are long, more than 5 minutes, or more than 3 seizures in an hour.
Okay, excellent. How about how does as epilepsy, how can it affect their educational environment, and how can families help educate and work with schools about their child's diagnosis and future?
Yeah. So for many of our children, their cognition before having first seizure or after second seizure or a diagnosis of epilepsy, their cognition is normal. They continue to thrive at the same level as they have been, and some of the patients, there is a need for testing for individualized education plan. There may be a need for 504 plans, and the difference between 504 and IEP or individualized education plan is individualized education plan has to do with the content and how you're going to deliver education, whereas 504 plan may be other accommodations. For example, a kid who have asthma or limited physical mobility issues, and that is not necessarily restricted to educational plans.
Excellent. Well, what resources would you recommend to families that when they're trying to find things on the internet, sometimes you can read stuff that's maybe not reliable?
Yeah, there's certainly a lot of options out there. I would highly recommend the epilepsy.com, which is partnered with the Epilepsy Foundation. Your local epilepsy foundation would be a very good resource, not only for information, but also for support groups. The Charlie Foundation website, it's a very good and well-done website for getting resources about ketogenic diet and dietary therapy for epilepsy.
Absolutely. I think we could talk all day about all the different treatment options and things that you guys encounter with families every day, but we're running towards the end of our time here. Cool. So I want to thank you so much for joining us. This was fantastic.
You're welcome. It's my pleasure.
Absolutely. Well, thank you everyone who watched, and thanks to those who sent in questions. You can catch the next Facebook Live video question and answer session. Will be on November 21st. Thank you everyone, and have a wonderful day.